So that was the patient, the family history of congenital heart anomalies presented during the early second trimester. First of all, because it was her first pregnancy and the father of the baby had the situs abnormality, this complex heart anomaly, most likely heterotaxis syndrome, and underwent 3 or 4 surgeries during his lifetime. So they were very concerned about the heart of the baby, and that's why she presented early. And at 14 weeks and 1 day, unfortunately, we suspected the heart anomaly. But now I'm going to present the second trimester scans just, to be a little bit more clear on the findings. And once again, we are starting our examination from the four-chamber view. This fetus was in a bridge presentation, so here is the left side and the right side, and the apex of the heart is pointing to the left. And what we obviously can see here, that the cardiac axis seems to be deviated to the left. So we are applying color Doppler. Here, color shows us normal inflow, so normal unrestricted flow through the tricuspid and mitral valve without any evidence of the insufficiency. And this is where it gets a little bit more interesting. So this is the sweep from the level of the four-chamber view towards the baby's head. And here we can see how the outflow tracts look. Okay. Any idea what we are dealing with? All right, so definitely we can see the vessel that overrides the septum, but tend to rise mostly from the right ventricle. And if you look very carefully at this vessel, we can see that there is kind of very soon, like right above the valve, it splits into two. You looked very carefully at the anatomy of this valve. And if you look here, you can see that the leaflets tend to be a little bit more echogenic than we would like them to be, and the color Doppler shows us the insufficiency. So then you see the combination of the findings that the vessel overrides the septum and the valve looks abnormal, thickened leaflets with a little bit of regurgitation or stenosis. The first thing that you need to think about, this is the common arterial trunk. We didn't have the specifically dedicated lectures during this course to that pathology, but this is the main differential diagnostic criteria from the other kind of truncal anomalies, that usually the valve, the truncal valve looks abnormal, shows some degrees of insufficiency or stenosis. So, and this is just to confirm that this is not an artifact, that this is a real insufficiency at that semilunar valve, and you can see that the jet of regurgitation is also pointing towards the right side. So, common arterial trunk most of the time sits right above the septum, but could be shifted more to the right side or to the left side. And then it's more to the right side, it presents more surgical challenging for repair. So this is our traditional 3-vessel and trachea view, and as soon as we suspected that this is just one single vessel that originates from the basis of the heart, and we are suspecting the common arterial trunk here, we want to take a look a little bit further and evaluate the type of the common arterial trunk. And for that, we would like to find the pulmonary arteries. Usually the trunk represents basically aorta. And then from the side of that big vessel, we can see the origin of the pulmonary arteries. It could be the pulmonary trunk that then divides into two. It could be separate pulmonary arteries. Sometimes the trunk could be it could have an interrupted arch. So there are lots of variations here. So the common arterial trunk is a very diverse group of the anomalies. And here we are looking at the proximal portion of the trunk. This is the valve, and we can see that vessel. And initially, they thought that this is the short pulmonary, main pulmonary artery, and then the division into two branches. But obviously, we can see here just one branch that is turning towards the right side. So in the second one, we were actually not able to see clearly, and we were looking for that. So, and here we can see the color Doppler. Color Doppler helps a lot with the identification of the origin of the pulmonary arteries from the common arterial trunk. And here again, we can see very clearly the right branch that turns to the right side. And surprisingly enough for us, so this is like the sagittal view, we can see that there is the left branch that originates from the ductus arteriosus. So that was very interesting for us to see. And to visualize the branches of the pulmonary artery, this image actually was obtained later in the pregnancy, and you can see that here is the truncal valve, there is the right branch, and here is the left branch. So that the left and right pulmonary arteries, they originating from the trunk on the different level. The right originates right above the truncal valve, and the left from the ductus arteriosus. So you may think that after birth, then the ductus arteriosus is going to close, so one lung would have very restricted blood flow, no flow, and the other one would have too much flow. So that may have some very challenging management of that patient. So what's the diagnosis? And as we said, that's the common arterial trunk, type A3. So basically, in this pathology, we have single vessel that originates from the basis of the heart, and exactly how this diagram shows, this is exactly what we saw in our ultrasound images. And again, do not assume if you can see the vessel right above the valve that it's going to give rise to both the left and right pulmonary arteries. So the pulmonary arteries can actually originate on the different level. So in that case was more or less clear. So here we are moving to the next case. Here also was the first pregnancy for that patient, presented for fetal echocardiogram at 22 weeks, the suspected cardiac anomaly during the routine examination in her doctor's office. So they did a great job. They suspected that there is an anomaly. So here again, we start, baby is in a breech presentation. We start from the evaluation of the four-chamber view. And here we have very traditional image for the conotruncal anomalies. We have the deviation of the cardiac axis to the left, and we can see the aorta that sits on the right side of the chest. So we're already suspecting right-sided aortic arch. So again, if you look at the four-chamber view using color Doppler, color doesn't provide any additional information. So the four-chamber view, other than deviation of the axis, looks perfectly normal here. So we can remember all the checklist parameters that we need to check here. But other than the cardiac axis deviation, nothing really striking. And the color Doppler shows absolutely normal blood flow across the AV valves. So evaluation of the left ventricle outflow tract shows very typical picture for conotruncal anomaly. So here we have the vessel that overrides the septum in contrast to the first case that we reviewed. So the valve here looks pretty normal. The leaflets are thin and not echogenic and opening, closing freely. There is no evidence of any stenosis or insufficiency. Then we look at the blood flow using color Doppler. So here we on the short axis view, and we can see that there is the aorta, and then there is the second vessel, again in contrast to the first case, and we were able to identify just one vessel. So here we have the second one, but look here, this is the significant obstruction of the right ventricle outflow tract. It's like very skinny here, so this is the very significant infundibular stenosis, and then we have a very, very skinny vessel that represents pulmonary artery. So, but the good news here that it's not an atresia, there is still the antegrade flow across that valve, even though it looks very narrowed. Well, our diagnosis most likely is the, what is our diagnosis? Tetralogy of Fallot, correct. So we have two separate vessels. One overrides the septum. There is a VSD and there is a subvalvular obstruction, so obstruction of the right ventricular outflow tract. So this is within the spectrum of tetralogy of Fallot. So here we look at the three vessel trachea view, and looking at the right ventricular outflow tract, again we can see very skinny vessel here. But what we can see, that we can see the bifurcation So we have like that straight vessel, like oblique, and usually even the aorta, even the pulmonary can get really small and very hypoplastic. You still can identify the branching on the left and right side, but you know, here we have nice color Doppler filling, and it seems that it's going straight to the right, okay? Also, we confirmed our suspicion made in evaluation of the four-chamber view that there is the right-sided aortic arch. So here is the trachea, aorta runs on the right from the trachea, and here is the superior vena cava. So what we are doing next, we are trying to evaluate the superior mediastinum and see if there is the pulmonary artery, you know, what's the structure of the pulmonary artery. And what was really striking, we were talking today a lot about the vasculature around the trachea, and here we can see the vessel in 2D and also the same vessel. Then we look in the color Doppler that originates from the aorta and runs in front of the trachea and kind of going to the left side. So that was very interesting for us. So, and then we obtained another sweep. Once again, right ventricle outflow, PA is skinny, and again, we can't see any evidence of bifurcation. And this is the view which is in between axial and sagittal. And here we can see very clearly that there is the pulmonary valve, trunk, and then it continues to the right. And from the descending aorta, there is the ductus here and the branch which is going to the left. So this is the situation. And once again here, right? So what's the diagnosis? And the diagnosis is that this is the anomaly, which is the spectrum of tetralogy of Fallot. But in this case, we have the discontinuous pulmonary arteries, also this pathology called hemitruncus, and also the right-sided aortic arch is present. So in this pathology, we have the pulmonary valve, we have the pulmonary artery, and then only right pulmonary artery is actually communicated to the trunk and valve in the right ventricle outflow tract. So the left pulmonary artery originates from the ductus arteriosus, and so then the left and right pulmonary artery are actually discontinued, so they are not connected. So very rare observation. So, but this is also the spectrum of tetralogy of Fallot. So the key point here that every time then you suspect tetralogy, you need to evaluate the branches very carefully. Every time then you suspect common arterial trunk, this is also recommended. And those two cases are very similar and easily can be mistaken. So that evaluation of the great vessels, then you suspect truncal anomaly, needs to be very careful so to differentiate between the different types. Thank you very much.